Good morning, everyone. Now let's take a break from the technology and go to the real classes. Welcome to our session on trauma. First, we have Dr. Halima. She is the Associate Professor from Assisi Medical College. She will talk about how to evaluate and classify ocular trauma.
Good morning, all. Today I'm going to deal with ocular trauma, its classification and evaluation. Ocular trauma is more common among younger age group and the elderly above 70 years. And the major contributors of ocular trauma are road traffic accidents. Regarding the classification, in 1996, Kun et al. Introduced a classification system for eye trauma, which is called the Birmingham Eye Trauma Terminology System. In this classification system, mechanical eye injuries are classified into closed globe injuries and open globe injuries. Closed globe injuries again classified into contusion and lamellar laceration. In contusion, there won't be any eye wall injury, but there will be structural damage inside. In lamellar laceration, there will be a partial thickness eye wall injury. Open globe injuries are again classified into laceration and rupture. Rupture means it's a full thickness eye wall injury, but because of a blunt trauma. Laceration again classified into penetrating injury, in which there will be a single wound, intraocular foreign body, and perforating foreign body. Perforating injury means there will be an entrance and exit wounds. International Ocular Trauma Classification, a classification system of mechanical injuries based on bed and features of globe injury at the time of presentation. And this system categorizes trauma by 4 parameters. Type means the mechanism of injury, grade based on initial visual acuity, presence or absence of RAPD, extent or zone of injury. This is widely used for recording purpose, and the types of open globe injury are rupture, penetrating, intraocular foreign body, perforating, and mixed. And these are recorded as A2, A, B, C, D, or E. And the visual acuity is graded in between 20/40 to no PL. And pupil is recorded as positive if RAPD is present and negative if RAPD is absent. And the zones are zone 1, limited to cornea up to the corneoscleral limbus. Then zone 2 means from the limbus to 5 mm posterior into the sclera. Zone 3, posterior to that 5 mm of anterior sclera. Closed globe injury types are contusion, lamellar laceration, superficial foreign body, and mixed type. Visual acuity grading and pupil is same as that of open globe injury. And the zones are, zone 1 is external, limited to conjunctiva, cornea, and sclera. Zone 2, anterior segment up to the posterior lens capsule. Zone 3 is posterior segment behind the posterior lens capsule. Ocular trauma score is again proposed by Kun et al. And this provides a simple system with few variables to predict final visual outcome of an injured eye. In this, initial visual acuity, globe rupture, endophthalmitis, perforating injury, retinal detachment, and RAPD are considered. There are certain disadvantages of Budd's classification in which adnexal injuries, destructive globe injuries, and non-mechanical injuries are not considered. So the classification system proposed by Dr. Shukla in 2017 is approved by the Ocular Trauma Society of India is a comprehensive classification. In this classification, along with the mechanical injuries, non-mechanical injuries are also considered. Ocular trauma associated with the other traumas are also considered, and different causes of ocular trauma are classified under environmental classification. Again, mechanical injuries are classified into adnexal and global injuries. Global injuries, again, classified into structural and pathological. Under pathological classification, along with closed globe and open globe injuries, destructive globe injuries are also considered. Now, how to approach a patient with ocular trauma? Before any history or examination, don't forget to make sure that the patient is systemically stable, and immediate attention should be given to chemical injuries, in which an immediate eye wash is important to remove the chemical particles. Then rule out open globe injuries so that your further examination will be careful. Now coming to a focused history, to know the mechanism of injury, whether it is blunt or sharp, metallic or vegetative, then symptoms like vision loss, diplopia, previous ocular history like surgeries, contact lens usage, eye trauma, prior poor vision. Then in case of injuries by animals, need of anti-rabies vaccination should be kept in mind. Then a detailed ophthalmic evaluation, which includes best-corrected visual acuity, pupillary examination, ocular movements, slit lamp examination, and ophthalmoscopic evaluation. Then don't forget to do a proper documentation and medico-legal registration if required. In orbit, look for crepitus, infraorbital anesthesia, enophthalmos, proptosis. Ocular movements may be restricted in case of muscle entrapment or cranial nerve injury. Then look for lid tears, canalicular injuries, canthal tears. In conjunctiva, rule out foreign bodies and retain chemical particles. Cornea, look for any full thickness or partial thickness wounds. Look for foreign body, high FEMA and or reaction in anterior chamber. Rule out iridodialysis, sphincter tears. Look for any subluxation, dislocation, or cataract in lens. Rule out commotio retina, retinal tears, and or choroidal rupture or retinal foreign body. And in optic nerve, rule out optic neuropathy, optic nerve avulsion, hemorrhages. IOP can be deferred in case of open globe injury. And if possible, you can do a photography also. Regarding investigations, CT scan, both coronal and axial views are taken in case of suspected intraocular foreign body or intraorbital foreign body, or if you suspect orbital fractures. If CTs are not available, go for X-ray. Ultrasound B scan for posterior segment evaluation in closed globe injuries. In open globe injuries, use with extreme caution. MRI has got a very limited role and is contraindicated in patients with the pacemakers or metallic implants. And to conclude, along with the proper history and a detailed evaluation, a proper documentation of all cases of ocular trauma is a must. Thank you.
Thank you, Halima. Next, we have Dr. Navina. She is Assistant Professor at Alappuzha Medical College. And she will talk you regarding the reconstructive techniques of lid lacerations. Over to you, Navina.
Good morning all. At the outset, I would like to thank KSOS for giving me this wonderful platform. So before going to lid laceration, our primary consideration must be given to the general condition of the patient. Airway, breathing, circulation has to be assessed. A complete history is mandatory. We have to document the visual acuity, check pupils and extraocular movements before any intervention. Never jump into lid laceration directly. Always rule out globe injury prior to lid laceration repair. Coming to examination of lid laceration, we have to note the site of the wound. Is it on the upper lid or lower lid? What is the depth of the wound? Is the lid margin is involved or not? Is there any tissue loss? If so, what is the width of the tissue loss? Is there any injury to canaliculi or levator muscle? So what are the red flag signs that we have to note in a case of lid laceration? Any full thickness injury, medial to punctum, always look for canalicular involvement. Visible orbital fat implies violation of orbital septum. Appropriate imaging has to be done depending upon the type and mode of injury. When to repair? Effort must be made to reconstruct tissues as early as possible. However, it is not wise to delay the repair over 48 hours. What are the surgical principles? Irrigate the wound with copious amount of saline. Remove all foreign bodies stuck to the laceration, especially vegetative matter. Preserve tissues as much as possible and plan for a layered closure. How to proceed? The anatomy of the lid will guide the technique of repair. We have got the anterior lamellae, which consists of the skin and orbicularis, and the posterior lamellae consisting of tarsal plate and the conjunctiva. And we have other structures like canthal tendons, canaliculi, and levator muscle. So coming to the surgical technique, if it is an anterior lamellar wound not involving the margin, simply reapproximate skin edges with simple interrupted sutures using 6 absorbable or non-absorbable ones. Take small bites 1 mm from skin edge and space them at least 2 mm apart. Always try to follow Langer's skin line, which will avoid undue scarring. If it is a full thickness lid margin wound, our aim is to restore the anatomy using 3 basic landmarks, that is the lash line, gray line, and the meibomian orifice line. Our first suture pass is through the meibomian gland orifice line. Each bite is 2 mm from wound edge and 2 mm deep. The lid margin sutures at gray line and meibomian orifice line are left long and they are reinforced by a suture at lash line. If it is an irregular laceration of lid margin, first convert it into a pentagon-shaped defect before closure, then follow the 3 suture technique. After completion of lid margin suturing, it should produce a slight pouting effect which will result in even healing of the wound. Tarsal plate alignment is achieved through partial thickness sutures through the tarsus with 5 or 6 upsole sutures, and the nodes are tied anteriorly to avoid corneal abrasion. Pre-placing the lid margin sutures before tying them helps to align the tarsal segments properly. Wounds with tissue loss. Most of the time, retraction of the tissue gives the appearance of greater tissue loss than the actual. So the defect can be closed by appropriately orienting the traumatized tissue. If it is a small tissue loss involving only the anterior lamellae, it can be allowed to regranulate by itself. If it is a full thickness lid margin wound with tissue loss, always evaluate tissue loss by trying to approximate the cut edges using 2 forceps and see if closure can be achieved without any tension. If that is not possible, we can think of lateral canthotomy and cantholysis, which will yield an amount of 6 millimeters of lid. If closure is not possible with that also, then you have to think of a tensile flap. Tensile flap is a semicircular myocutaneous advancement flap. For lower lid defect, the curve should arch superiorly, and for upper lid defect, the curve should arch inferiorly. If it is a lower lid defect involving more than 50% of the lower lid area, then Hughes tarsoconjunctival flap is the choice. Here, the tarsoconjunctival advancement flap is taken from the upper lid and is advanced towards the lower lid and sutured to the corresponding points. And the anterior lamellae is reconstructed from the skin over the cheek area. If it is if the lid defect is more than 50% in the upper lid, then the Cutler-Bayer procedure is the choice. Here, the cutaneo-myoconjunctival flap is taken from the lower lid, sparing the lower lid margin, and this flap is passed underneath the lower lid bridge and sutured to the corresponding point. This is a 2-stage procedure, and second surgery is done after 6 to 8 weeks. Lid tear associated with canalicular injury. The cut end of canaliculus is seen as a shiny white ring surrounded by orbicularis muscle under microscope with high magnification. If cut end is not visible, you can pass fluorescent dye or air through the opposite punctum. Canalicular repair, an internal stent can be passed to bridge the laceration and re-establish the continuity. After passing the stent, the marginal wound is repaired. In this figure, it is a mini Monaca stent. It is a monocanalicular self-retainable stent is shown. So this is a short video of canalicular repair. Sorry. So here the punctum is dilated with a nettle-ship punctum dilator, and the monocanalicular stent is passed through both cut ends. The top of the mini Monaca stent is having a collarette, which nicely fits over the punctal area. After passing this stent, the pericanalicular tissues are sutured back in position. So this is the final position of mini Monaca stent. Eyelid avulsion needs layered closure. Layered closure should begin with deep closure of medial and lateral canthal tendons. Levator aponeurosis or muscle injury can be repaired with 6 or upsole sutures. Canthal injuries should be directed posteriorly, and the repair is done using a permanent suture, either 4 or 5 or proline, anchored to the periosteum. As a general rule, the conjunctiva and septum are not closed in eyelid avulsion. Conjunctival sutures will lead to corneal abrasion, and closure of septum may result in lag of thalamus. Postoperatively, skin sutures can be removed by 5 days and lid margin sutures by 7 to 10 days. Wound massage can be advised after 3 to 4 weeks to prevent cicatricial changes. To conclude, lid and adnexal injuries requires meticulous planning to achieve best anatomical result. Our aim is to restore anatomy, contour, and function of the eyelid. Most of the time, multidisciplinary approach is required. Thank you.
Thank you, Navina. Next, we have Dr. Reshmi. She is a cornea specialist working at Fort Hospital, Trivandrum. She will talk regarding the suturing tips in cornea scleral wound repair.
Thank you, Rejina, and thank you to KSOS for giving me this opportunity. So I'll be dealing with open globe injury, or actually corneal tear repair. So the principles that we follow generally is a restoration of the optimum visual function, restoration of anatomical relationships like limbus, and with a watertight closure, removal of any anterior segment foreign body that we see, prevention of glaucoma, amblyopia, infection, or the need for a secondary reconstructive repair. That means that when we do the primary corneal tear repair itself, we have to achieve as much as perfection and cosmesis so that we can decrease the scarring and the amount of astigmatism that later goes in. Of course, we need the proper prepping of the patient whenever required. We need a general anesthesia, and adequate antibiotics, both topical and systemic, should have been started even prior to taking the patient onto the OT table. So this is a video about how a corneal tear repair is done. So first of all, we under asepsis place a wire speculum. If it's a small corneal laceration with a formed anterior chamber, then we don't have to even enter the anterior chamber. We can directly go on to suturing. If it's a less stable wound, with a shallow anterior chamber, then we have to form the anterior chamber with visco. That is, we have to first place a side port. So here, while placing a side port, I want to emphasize something is that you don't have to place a side port at a particular clock or anything. The basic thing is that you have to place it where you are comfortable and the instruments reach the corneal tear. And if sometimes it's difficult to place a side port initially in itself, so what we can do is put the visco in through the corneal tear itself and then put the side port properly and then put adequate visco later. So first thing is we have to then wash thoroughly both the exterior and the anterior chamber with Simcoe cannula, and then inspect the wound for any foreign body or inspect it for any foreign body or iris incarceration. If there is iris incarceration, 2 points that we have to deal with here is, before repositing it, one thing is if it's a necrotic iris, you should just do abscission and do not reposit it. And if it's a healthy looking iris, then again one thing is there will be an inflammatory membrane on it, which you should have to probably peel it off and remove it before prior to repositing it. And after that, of course, there's a suture placement, which we use 10-0 nylon suture with fine spatulated design, interrupted sutures about 1.5 mm long, 90% depth, neither deep nor shallow it should be, and avoid visual access as far as possible. And we use a no-touch method, that is, as far as possible, do not touch the corneal tear edges. Coming to two different types of wounds that we usually deal with is the perpendicular wounds, in which the external wound corresponds to the internal wound, in which the only thing that you have to be careful is the corneal tear, the suture should be equal length on either side of the tear. That is, in the picture you can see the A is equal to B. This is the right way of placing it. But if you have a shelf wound, for example, if you cut a cake in a sliced way, you have an external wound somewhere, but the internal wound, lip will be somewhere else. In this case, A is equal to B is not what we have to follow. We have to look at the inner lip, and there is where the suture should be on either equal on either end. That is, in the marker shows which is the right thing. Coming to the different types of tears and which suture you have to place first, that's very important. So the first one is a linear laceration, in which you have to place a central suture first, and if it's in the pupillary axis, then don't place it in the pupillary axis, but on either side of the pupillary, straddle it on the pupillary axis. If it's a gaping laceration, it's difficult for us to approximate the thing and know which is the center. So the best thing is start from one end and then work towards the other end. If it's an angle laceration, then close the acute angles first and then only go to the rest of it. The rest of it I'll be dealing in separate slides. One more thing about linear laceration is we generally use a Rousey-Hayes technique, in which in the peripheries we put long compressional sutures, that is with a good suture tension, and in the center, as we move towards the center, we put short, just apostential sutures. So the thing is, when we come to the center, the peripheries might get loose. So go back and redo those sutures. You have to take adequate time and redo the sutures. There's no problem in that. And of course, bury all the sutures away from this pupillary axis. Coming to two situations where you don't generally require sutures, lamellar tears, in which case you can just do patching or even bandage contact lens with antibiotic coverage. But again, 2 points over here is, if you see a foreign body like this, then you have to remove it as well as wash under that lamellar tear. And another thing is, if you have a thick lamellar flap, then probably you have to put one suture so that properly opposes. If it is a corneal tear less than 2 mm, then you have a BCL with or without synovial glue is adequate. The stellate tears are one difficult way, tear to manage. So usually we follow the Atkins method, that is just crisscross sutures across the wound, and if required, if to get watertight closure, we have to put a bandage contact lens in the end. But ideally, Eisner's method is the one that you should use, in which you have to actually place intralamellar, partial lamellar incisions in between these leaflets, and then thread the suture through these lamellae and through the leaflets of the corneal tear, and finally tie it in the end like a purse string and bury it in that lamellae. So this attains good closure and less astigmatism. Coming to corneoscleral tears is a very common thing, and you know the first important suture to place a limbal suture. Take your time and approximate the limbus very carefully. The rest of your job becomes easy then. Corneal wounds, we discussed about it. Coming to scleral wounds, slightly different. We have to use a better suture, like a thicker suture like 7-0 or 8-0 Vicryl. We have to do a limbal peritomy in all cases of a limbal tear to see if there is an additional scleral wound and see the complete extent and close it. But suppose you have a case like the one on the where you don't know what's happening behind that hemorrhagic conjunctiva, then it's difficult to find the complete extent, in which case you explore as you go. So you see a scleral tear, you close it, and then you further explore and see the scleral tear. One additional technique that will help here is to leave the preceding suture long, so that you can use it as a bridle and push it down so that you can see further posteriorly. And also the help of an assistant is required, because if you have an uveal prolapse here, then it's best not to cut it, but rather just push it inside with a blunt instrument and suture it. Here you don't have to follow the no-touch technique, but rather you have to hold the scleral edge tightly and then do the suturing. If there is vitreous, anterior vitrectomy is required. If the tear goes under the muscle, if you are trained enough for that, then disinsert, repair the defect and reattach. But if you're not, then probably you can take it for a secondary closure. All scleral tears must also be buried, and conjunctiva should be closed with an 8-0 or 9-0 Vicryl. Coming to tears with necrosis or tissue loss where it's difficult, it's just cheese wires. In those cases, you have to plan a patch graft in the primary setting itself, if possible, if you're in a center like that, or you can actually do a Tenon's grafting also. Post-operatively, these patients should be given adequate topical and systemic antibiotics, and in some cases antifungals also. Topical steroids is questionable, at least in the first few days, with there's a risk of infection, but after a while you have to start it. Meanwhile, you can actually give systemic steroids and cycloplegics. Visual rehabilitation, we plan for visual rehabilitation after 3 months, because once the sutures have all come off, and while removing sutures also, first only alternate sutures and then only the complete sutures. And once that is removed, you have to actually give spectacles, or in many cases, corneal astigmatism, then you have to give a contact lens like RGP or a soft contact lens. And if it's really scarred cornea, then you have to go in for optical keratoplasty. Thank you.
Thank you, Rashmi. Now we have Dr. Grishma. She is Assistant Professor at RIO Trivandrum. She will be talking about traumatic cataract and hyphema.
Good morning to all. I thank KSOS for this opportunity. Coming to my topic of today, traumatic cataract and hyphema. So if we have a case scenario like this, what next? So that is the scope of our discussion today. Coming to traumatic cataract, it can be the result of any form of trauma, be it a blunt or penetrating injury, electric shock, lightning, infrared radiation, or ionizing radiation. These forms of trauma can lead to hydration and resultant concussion cataract. So a thorough systemic and ocular examination is mandatory, and in the lens we have to specifically look for the anterior lens capsule rupture, any Voshier's ring or wrinkling of the ALC. Cataract can be an early or a late onset rosette cataract, a total cataract, or progression of immature cataract. The position of the lens is important, as in we can have a subluxation, a dislocation, or a phacodonosis, and any intralenticular foreign body also should be noted. The point here is any intralenticular adhesions may mask a phacodonosis, and in all cases we better consider that ZE is present before we take in for a surgery. Coming to the management, traumatic cataract can be either primarily extracted or as a secondary procedure. Primary is done when there is a dense cataract, when there is associated capsular rupture, and when there is phacomorphic glaucoma. This procedure decreases the risk of glaucoma and amblyopia in future. A secondary procedure is better because the eye is quiet. We can get a better biometry, and if the biometry is not possible, we can either do a secondary IOL implantation or the calculation can be based on the fellow eye. In open globe injuries, we generally defer a primary IOL implantation even if the traumatic cataract is extracted because of the risk of endophthalmitis. Intraoperative procedure depend on the surgeon and the patient factors. We can plan any of these procedures. This is the only case when we actually do ICC in this era also. And pars plana lensectomy is done if the age of the child is less than 2 years. It is usually done under a general or a regional block. And here we have to use some agents cautiously. The intracameral lidocaine and riponablu can go in through the area of the zonal dialysis into the vitreous. Lidocaine can cause a retinal toxicity and riponablu can stain the vitreous, thus impeding the visualization of posterior lens capsule. The incision and the rhexis should be ideally initiated from the zonal dialysis. Every time this may not be possible. And any time after the rhexis, we can implant capsular support devices. It may be a capsular tension ring, a modified capsular tension ring, capsular tension segment, or capsular retention hooks. So these are made up of PMMA. They either come as a preloaded system in which they can be injected into the equatorial area or inserted via a Kellman-McPherson forceps. In case of small zonal dialysis less than 4 clock hours, we can either manage with an intraocular lens in the back or we can inject a capsular tension ring. And more than 4 clock hours, we can either suture a Sionis ring or a capsular tension segment. These are generally contraindicated when there is a can opener capsulotomy or posterior capsular tears. Coming to the standard FDA approved CTRs, so they are either Mosher ring or optic ring. These are flexible rings which can be compressed. So generally we inject the rings into the equatorial plane through the rhexis. The Sionis ring, we usually suture it via a non-absorbable suture. Generally a tensor or Prolene is used and the suture is secured beneath the partial thickness scleral flap. Hydrodissection also should be very meticulous, it should be minimal, and it should be preferably done in the direction of zonal dialysis. Our aim is to prevent the enlargement of dehiscence. Phaco settings are very important, it can be done in or out of the bag. The settings should be low vacuum, low aspiration flow rate, and low infusion bottle height. The anterior chamber fluctuations should be kept at minimum. At any point the surgeon feels he should convert into more appropriate techniques. And the cortex aspiration should be tangential and never radial for the fear of increasing the zonular dehiscence. And automated anterior vitrectomy should be done to clear the anterior chamber of vitreous, and IOL implantation depends on the capsular support and the surgeon preference. So coming to the second topic of today, traumatic hyphema. It usually occurs in young males, can be a result of blunt injury or open globe injury, and the bleeding points are generally from the peripheral iris, sphincter, or the anterior ciliary body. The hyphema, we know it is graded like microscopic or a microhyphema. A layered hyphema we grade from 1 to 4. The higher the grade of the hyphema, the higher is the risk of secondary glaucoma. It can be a total hyphema wherein the whole anterior chamber is filled with bright red blood, or an 8-ball or a black ball hyphema. In this, the actually blood looks blackish because of the hypoxia and impaired aqueous circulation, and there is a high chance of pupillary block and a secondary angle closure glaucoma in such patients. In cases of trivial trauma, always rule out cause of spontaneous hyphema. We have to look the iris carefully for any iris lesions. We have to see for any intraocular tumors like retinoblastoma, an IOL rubbing against the iris causing the iris chafing, or any systemic disease causing coagulation. Coming to complications of hyphema, there could be a hypotony, there could be secondary glaucoma wherein there is a risk of optic neuropathy, there is rebleed because of clot lysis and retraction. The problem with rebleed is that there is high chance of refractory glaucoma, and gonioscopy we usually delay for the fear of rebleed. It is done after a period of 5 to 7 days. Coming to the corneal blood staining, a triad of hyphema, glaucoma, and endothelial damage. This leads to corneal blood staining. So what happens here is that hemoglobin from the breakdown of RBCs, they enter the posterior corneal stroma wherein they are broken down into hemosiderin. This gives it a yellowish appearance. It clears very slowly and it clears from the periphery. That's why it takes even years, or it might be a permanent process. The problem here is in pediatric age group there can be amblyopia, and this looks like clear lens dislocation, and it should be very importantly distinguished from clear lens dislocation. The treatment, our aim is to decrease the rebleed and the treat inflammation and glaucoma. Our mainstay is topical corticosteroids, cycloplegics, and AGM. Antifibrinolytics are a little controversial because in the final visual outcome, they actually do not have any significant outcome. They do prevent rebleed, but they have multiple systemic side effects. Surgical intervention is planned at the first sign of corneal blood staining or persistent IOP elevations. As you all know, this is what we follow: more than 25 for 5 days, more than 35 for 7 days, more than 60 for 2 days. These are done to prevent any corneal blood staining, peripheral anterior synechial formation, and to prevent optic atrophy. Or any hyphema resolving to less than half within 8 days also should be surgically evacuated. Sickle cell anemia, of course, is uncommon in our country, but this should be also kept in mind. So if any such patient comes, they have an increased risk of CRAO and ischemic optic neuropathy, and early surgical evacuation is planned, and certain drugs like carbonic anhydrase inhibitors and hyperosmotics are avoided in such patients. So summary for today is all traumatic cataract expects ulnar dialysis even if there is no phacodonosis, and always keep these capsular support devices in such cases, and in trivial trauma look for causes of spontaneous hyphema. Never miss CBS or secondary glaucoma. This should actually cost us because it might lead to a permanent visual disability. Thank you. Now let me welcome Dr. Rejina Mohan PT. She is the vitreoretina consultant in Chaitanya Eye Hospital, Trivandrum. She'll be talking to us regarding the posterior segment complications of ocular trauma. Over to Rejina.
Okay, good morning everyone, and thank you KSOS. Now we will move on to posterior segment involvement in ocular trauma. So many of the time, the posterior segment examination is very difficult due to corneal injury, hyphema, cataract, and vitreous hemorrhage. But whenever there is a zone 2 or zone 3 injuries, you should be expecting more posterior segment complications. And when to suspect an occult rupture? When the vision is very poor with PL or no PL, when there is dense SCH with enough hypotony, restricted EOM, hyphema, shallow AC, and vitreous hemorrhage, an occult rupture to be suspected and explained to the patient. Scleral laceration, Dr. Reshmi has already told, an immediate primary wound repair has to be performed with adequate exposure but with a minimal traction. A stepwise closure should be done from the limbus going posteriorly. So whatever retina or the choroid which has prolapsed should be very carefully and softly reposited while suturing, and you can ask for a help of your assistant. And whatever vitreous which has come out should be cut with an automated cutter without a traction. And our aim should always be for a watertight closure so that it will help in your secondary surgeries. So when to do a B scan? So all the blunt trauma, when your posterior segment view is poor, we can ask for a B scan. But in lacerated cases, the B scan is usually deferred till the primary repair. So this is over the concern of mechanical compression, which can expulse the contents, increase risk of infection, and a lot of artifacts can happen with the ill-contoured eye globe. So B scan is usually done after primary repair. And for the preoperative imaging, CT is the ideal choice. So we will just see some few B scan findings. In this, you can see the vitreous hemorrhage, then a very small tag from the RCS complex, which can be a tear or a break. Then PVD, we can see retinal detachment, posterior dislocated lens. And sometimes we can see the rupture of the posterior capsule also if we see very carefully, serous or hemorrhagic choroidals. And posterior rupture we can see as a discontinuity of the RCS complex with a hypoechoic lesion around the lesion, and vitreous hemorrhagic echoes can be seen in the vitreous cavity also. And of course the intraocular foreign bodies which can be identified with the B scan. So IOFB should always be suspected when the history is suspicious, when it is a high velocity workplace injury. At this point, we should have a very meticulous slit lamp examination, look for corneal scar, iris holes, any tract into the lens, cataract, and a thorough indirect should be done to see all the periphery, and special care to be taken to see the inferior periphery. Okay, vitreous tract and intraretinal hemorrhage may give you a clue regarding the site of impaction of the foreign body. And if the indirect examination is delayed, in cases of laceration and all, sometimes the foreign body can be missed due to capsule formation. So whenever there is a very good vision, no signs of endophthalmitis, and no significant structural damage, we can always watch an intraocular foreign body with a very careful examination every 2 to 3 months with a slit lamp indirect and ERG if possible. But if there is signs of endophthalmitis, always try for a primary removal of the intraocular foreign body, but if the view allows only, or else first do the primary repair, IOFB removal later. So when to suspect a post-traumatic endophthalmitis? The high-risk factors include a dirty wound with a delayed presentation, large wound with a tissue prolapse, old age, and a retained intraocular foreign body. In severe cases, the presentation is very easy and easy for diagnosis, like hypopaeon, severe lid edema, chemosis, congestion, and pain will always be out of proportion to the injury. But in subtle cases, the diagnosis can be very difficult, but we should carefully look for AC reaction, vitritis, retinitis, and periphlebitis. And if the inflammation is progressing even after your suturing, you should always suspect an endo. Serial B scans will also help you to see the increase in the vitreous echoes. And whenever there is any kind of suspicion, always go for a vitreous tap with a gram stain KOH and culture and treat accordingly. And early vitrectomy is indicated when there is severe vitritis with IOFB and RD. Now after this bloody complications, we will just move on to common complication. One is commotio retina that we know is a posterior segment whitening, commonly seen. Actually, it resolves very nicely after 3 to 4 weeks with a very good visual recovery, and the vision is impaired only if it is associated with a severe RPE damage with subfoveal hemorrhage or choroidal rupture. Macular holes can be immediate or late, but most of the time spontaneous recovery is reported in macular hole up to 6 months. So always plan a surgery after 6 months only. And the closure is, spontaneous closure is very common in young patients when the hole is small and there is a good fluid, when there is no fluid cuff around the macular hole. Choroidal rupture, it basically happens due to the mechanical compression where the non-elastic inner choroid along with the RP and the Brooks breaks. Clinically, if you see, you will be seeing a subretinal hemorrhage. Sometimes you can see a bare choroid in between. But these cases, we need a very regular follow-up because they tend to develop the scars. And common sites for choroidal rupture are the macula and the peripapillary area. And carefully, we have to follow up this patient for the development of a CNVM, which should be treated accordingly. And when there is a retinal rupture along with the choroid, it is called a retinitis clopiteria. It is very known to produce fibrovascular proliferations. And identifying a retinal break is very important because 80 to 85% of the traumatic tears are known to develop RD. So serial indirect ophthalmoscopy has to be done. And the last, I will just show you one case. This is a 12-year-old boy. He came to our OPD with a blunt trauma while skating inside the room. So he presented with a lid laceration and no PL vision. And the CT MRI didn't show much positive findings, but B scan showed a hypoechoic area at the ONH site. So with the clinical finding, the B scan and the no PL, we made a diagnosis of optic nerve head avulsion. So making this diagnosis is very important because all other optic nerve pathologies, we do some kind of treatment. And this, we can avoid unnecessary treatments even though the prognosis is very bad. So, thank you all, but make sure you always do a very good indirect ophthalmoscopic examination, that too very serial with a long follow-up. Thank you.
Thank you, Dr. Rejina. Next, the keynote address, Principles in Managing Blowout Fractures, which is supposed to be delivered by Dr. V. Manaksha, will be done by Dr. Navina. So, Dr. V. Manaksha, who is the Chief of Orbit and Oculoplasty Department in Arvind Eye Hospital, Tirunelveli, is supposed to take this lecture, but due to unavoidable circumstances, sir is not able to attend this. Over to Navina.
So good morning all. So I will be delivering Dr. Maniksha's keynote address. Thank you Dr. Maniksha for sharing his slides. So before going to orbital blowout fractures, let's recollect some anatomy. The roof of the orbit is formed by the orbital plate of frontal bone and the lesser wing of sphenoid. So the roof will separate the orbital cavity from the anterior cranial fossa as well as the frontal sinus. The frontozygomatic suture is a part of lateral wall. Lateral wall is formed by zygomatic bone, greater wing of sphenoid and part of frontal bone. The superior orbital fissure will separate the roof from the lateral wall, whereas the inferior orbital fissure will separate the floor from the lateral wall. The floor is formed by the zygomatic bone, the maxillary bone and the orbital process of palatine bone. And the medial wall is formed by the frontal process of maxilla, the lacrimal bone, the ethmoid bone and the body of sphenoid. The infraorbital foramen is situated in the floor. It is just in the posteromedial aspect of orbital floor. Now coming to blowout fractures, a blowout fracture results from an impact of a blunt object of size larger than the orbital aperture. The most common site is the posteromedial aspect of orbital floor, medial to neurovascular bundle, infraorbital neurovascular bundle. And in the medial wall, the lamina papyracea is the most common site. Classification of orbital fractures. Fractures limited to the internal orbital skeleton alone, and the fractures involving orbital rim as well as the internal orbital skeleton. Third is the fractures of orbit associated with other fractures of facial skeleton, such as zygomatico-maxillary fracture, naso-orbito-ethmoidal fracture, frontal sinus fracture, and Lefort's 2 and 3. The fourth one is orbital apex fracture. So coming to classification of blowout fracture, there are two types. Pure fracture, which includes all orbital, it involves only the orbital walls and the rim is paired. In impure fracture, orbital wall as well as rim is involved. Open door fracture is large, displaced and comminuted, whereas trapdoor fracture is linear, hinged and minimally displaced. Coming to the mechanism, first is the retropulsion theory or hydraulic theory of Smith and Regan. Here, when an object larger than the size of orbital aperture is striking against the orbital aperture, there will be rise in the intraorbital pressure, which gives away at the weakest point of orbital floor, and it will result in fracture of the orbital floor. So this is actually a protective mechanism to our globe. Next is the buckling theory or transmission theory of Rejina. Here, any force applied to the rim will get transmitted along the floor of the orbit. The floor buckles and fractures, whereas the rim will return back to its normal position. Clinical features. Clinical features mainly depends upon the severity of trauma and also the time interval between the injury and presentation by the patient. Early features include pain, eyelid ecchymosis, edema and hematoma. There can be subcutaneous emphysema. Neurosensory loss of infraorbital nerve, if present, is pathognomonic. So there will be sensory loss in the ipsilateral cheek area, ipsilateral teeth and also the tip of the nose. Proptosis can be due to either orbital hematoma, edema or air in the orbital cavity. Late features include enophthalmos, hypoglobus and superior sulcus deformity. All three are due to loss of orbital volume, and this enophthalmos can lead to secondary pseudotosis. Patient can also complain of diplopia and trismus or depression of malar eminence. What are the reasons for limitation of ocular motility? It can be either due to entrapment of connective tissue septa, extraocular muscle within the fracture, or it can be due to hematoma or edema in the orbital fat adjacent to the fracture. Another reason is hematoma or contusion of the extraocular muscle itself. It can be also due to palsy of extraocular muscle or Volkmann's ischemic contracture of entrapped extraocular muscle. What is white-eyed blowout fracture? It is an ophthalmic analog of pediatric green stick fracture. Here, there is lack of external periocular signs, hence it is known as white-eyed blowout fracture. Pediatric bone is a developing bone which is highly elastic. So here, the fracture site will act as a hinge, which allows the contents to escape into the maxillary sinus, and it snaps back like a trapdoor, resulting in severe restrictive external ophthalmoplegia. There is high risk of necrosis of entrapped ocular muscle here, so it is an indication for immediate surgery. So coming to evaluation, we have to start with the basic evaluation of airway breathing and circulation, and a proper history has to be noted. And functional examination, including visual acuity, color vision, and examination of pupil have to be done. And ocular motility also. If possible, a slit lamp examination and fundoscopy has to be done, and appropriate imaging should be advised. A force duction test should be done to rule out any entrapment of muscle or intermuscular septum. So, X-ray skull with head tilted back, that is Waters' view, is a basic investigation to rule out any floor fracture. Although it is a basic investigation, it will give only less information regarding the fractures. We can see flow disruption, absent bony segment, bowing into the sinus, sinus opacification and all. The gold standard one is the CT scan. We have to get a coronal, axial and sagittal sections with 1.5 mm to 2 mm cuts. And in CT scan, we have to see for the prolapse orbital fat, and that is known as the teardrop sign. And also we have to see for any extraocular muscle entrapment or hematoma in the intraorbital cavity. So coming to management, we have to ask the patient not to blow their nose or hold the nose while sneezing. Antibiotic prophylaxis should be started if the CT shows evidence of chronic sinusitis. Nasal decongestants and oral steroids have to be given. Oral steroids will decrease the edema, and it also prevents diplopia by decreasing the fibrosis of extraocular muscle. Not all cases of orbital fractures require surgery. So observation can be done in case of minimal diplopia, which is not in primary or down gaze, or patients who are having good ocular motility, and those who are not having any significant enophthalmos or hypophthalmos. Immediate repair has to be considered in non-resolving oculocardiac reflex with entrapment of muscle. So here, due to rise in the intraorbital pressure, the stretch receptors are stimulated, which will lead to a vagal response featuring bradycardia, heart block, nausea, vomiting and syncope. Another indication is early enophthalmos or hypoglobus causing facial asymmetry. And of course, in white-eyed blowout fracture. Repair has to be done within 2 weeks in case of symptomatic diplopia with limitation of movement in either up gaze or down gaze within 30 degrees of the primary position, with positive force duction test and a positive radiological finding of floor fracture. And it should be done in cases of large floor fracture, that is involving more than half of the orbital floor, and in case of significant enophthalmos more than 2 mm, and a case of progressive infraorbital hypoanesthesia. Surgical principle, we have to assess the orbital floor, release all entrapped soft tissues and muscle, and we have to strengthen the floor with the use of implants. Coming to surgery, force duction test should be performed to assess the entrapment in the preoperative period, intraoperative as well as in the postoperative period. Surgery is usually done under GA. The 3 approaches are the transconjunctival, cutaneous and transantral mainly. So cutaneous approach includes subciliary, which is 2 mm from the lash line, subtarsal, which is 4 mm from the lash line, and it can be also over the inferior orbital rim. Other incisions are transcarangular and transconjunctival. Transconjunctival is the most preferred one, but due to its least accessibility to the floor, we have to combine it with lateral canthotomy and cantholysis, so swinging eyelid approach. So what is an ideal orbital implant? So ideal orbital implant should give a good structural support to the defect. It should be non-reactive and it should get easily positioned, and it should be easily available. Coming to the types of implant, implants can be classified as organic and non-organic or synthetic. Under organic comes the autologous and allogenic. Under autologous, it comes the bone, cartilage, fasciolata, and periosteum. And allogenic includes irradiated bone, lyophilized cartilage, lyophilized dura extra. And among the synthetic material, non-metallic permanent ones are porous polyethylene, metallic ones are titanium, and resorbable ones are polylactic or polyglycolic acid polymer. Coming to titanium implant, it is used to fill very large defects and in case of multiple fractures where rigidity is required. It is chemically inert and tissue tolerant. It is highly corrosion resistant and also radiopaque. And there is no donor site morbidity. The disadvantage is that it has got sharp edges. Sometimes it can irritate the surrounding soft tissues, sometimes chance of exposure. And it is a permanent implant. Next is porous polyethylene. It has got a smooth surface which allows the tissues within the orbit to move freely. And it has got multiple pores which will allow tissue and vascular ingrowth. Hence it is biocompatible. Disadvantages are it is not radiopaque and there is lack of rigidity. Composite implant, it is titanium reinforced porous polyethylene. So the titanium has got high strength, stability, and it is radiopaque, whereas the polyethylene has got smooth surface allowing the vascular ingrowth. Next is the osteomesh or polycaprolactone. It is a biodegradable polymer. Like it is similar to our cancellous bone in human. It is a porous implant, ideal for small defects. It provides mechanical rigidity and there is no donor site morbidity. It also allows tissue ingrowth. The disadvantage is that it is not useful for medium or large defects and it is very costly. Bone graft is autologous, inert. It is bioresorbable. There is less chance of infection or extrusion. Disadvantage is long operation period and also donor site morbidity. This is a small video showing orbital floor fracture repair. This patient is having left thigh orbital floor fracture. After doing an FDT, a transconjunctival incision is made with Elman's cautery. Then periosteum is elevated and the fracture site is identified with the help of malleable retractors. And once fracture site is identified, we have to release all the entrapped contents back to the orbital cavity. Before placing any implant, we have to visualize the complete ring of fracture segment. So first a dummy material is placed to assess the size of the implant needed. After that, it is removed and the original implant is reshaped and resized according to the dummy material. The implant is placed at the site of the defect, completely covering the fracture ring. And the wound should be closed, first the periosteum and then the conjunctiva. Postoperatively also, you have to, before closing, we have to check for force duction test. Transconjunctival approach has the advantage is that it has got a better cosmesis and less chance of ectropion and lower lid retraction. The disadvantage is that it can lead to corneal abrasion and symblepharon. Cutaneous approach has got, like it is easy to perform, wide access to floor of the orbit, but there is high chance of postoperative ectropion and scleral show, and there is scar formation, external scar formation. Nowadays, surgeons prefer mostly the endoscopic approach, endoscopic transantral approach for the repair of orbital floor via maxillary sinus. And it is especially useful in repairing floor fracture of trapdoor variety. So using an endoscope, you can get a better visualization of the fracture site area and also you can position the implant nicely to the fracture ring. Important surgical points. Visualize the entire fracture margin prior to the implant placement and it should be placed subperiosteally and it should cover all boundaries of the fracture without any residual herniation and it should rest at least 3 to 4 millimeter posterior to the anterior orbital rim. And the implant should not protrude into adjacent sinus or NLD area. The edge of implant should be smooth following customization. If FDT is repeated after implant placement and if it appears to be positive, then you have to remove, resize and reposition the implant. And one word about navigation surgery. Nowadays, image-guided navigation surgery is also popular, where the surgeon can get a real-time image of the, what he is doing, and he can get a mirror image of the contralateral orbit, which will help in proper placement of implant. Postoperative protocol. We have to give analgesics and antiemetics, monitor extraocular movements. Regular follow-up should be done in 1 week, 1 month, 3 months, and 6 months. Visual acuity and pupillary examination have to be done. Systemic antibiotics and steroids have to be given. CT scan can be taken for proper implant assessment, placement assessment in case of titanium. Complication, there can be infection, implant migration on epiphoros secondary to impingement of the implant in the nasolacrimal duct area, worsening diplopia, lower ideal retraction in case of external cutaneous incision, residual inophthalmos or hyperglobus. Visual loss can be there due to retrobulbar hemorrhage or injury to optic nerve from a displaced orbital implant. How to prevent complication? Gentle manipulation of the tissues, avoid undue pressure to the globe, meticulous hemostasis, and use a properly sized, shaped, and nicely positioned implant. Medial wall fracture is very commonly asymptomatic, can have entrapment of medial rectus, and approach is through Lynch or transcarangular or medial fornix incision. Take home message is that we have to get a detailed history regarding the mode of injury and time of injury. Look for systemic complication. Orbital fracture repair is challenging. Timely repair gives better results. Titanium for larger fractures and porous polyethylene for smaller defects. Multidisciplinary approach is necessary. Thank you.
Thank you, Navina.